from the SOLO1 study where she was the lead investigator.
And I'm advancing here. Well, good morning or almost afternoon. It's my pleasure on behalf of the SOLO1 investigative team to present some of the data that we'll be presenting tomorrow in the presidential session from the SOLO1 trial, which is an international randomized phase 3 trial evaluating incorporation of olaparib maintenance following platinum-based chemotherapy for women with advanced ovarian cancer who harbor a BRCA mutation. These are the disclosures for the investigators listed on the manuscript. And Dr. Banerjee outlined this, while ovarian cancer is a highly treatable disease, owing in large part to its exquisite chemosensitivity, especially in chemotherapy-naive patients, the percentage of patients who survive disease-free for long periods of time is dismally low and hovers in the 10 to 15% range. If we are going to make meaningful improvements on that rate, it has to be with improvements in frontline chemotherapy or frontline treatment. As it stands now, and as Dr. Banerjee pointed out, the vast majority of patients recur within 3 years of diagnosis, and even though their cancer may remain highly treatable, they are no longer considered curable. SOLO1 is the first international phase 3 trial to evaluate incorporation of maintenance olaparib or any maintenance PARP inhibitor in the frontline setting. And the study schema is demonstrated here. Women with advanced high-grade serous or high-grade endometrioid cancer who harbored a BRCA mutation, had an excellent performance status, and had at least an attempt at a cytoreductive surgery, were randomized in a 2-to-1 fashion to olaparib tablets given twice daily or placebo. A key stratification factor was whether they entered the study with a complete or partial response at the conclusion of their chemotherapy. And that's defined as a complete response would be a patient whose CT scan or MRI at the end of chemotherapy shows no evidence of disease and their serum blood marker CA-125 is within normal limits. A partial response patient would be a patient who ended chemotherapy with at least a 30% reduction in their measurable disease, or perhaps they still had some evidence of disease on their imaging, or even someone who had normal imaging but still had a slight elevation in their CA-125. Those would be classified as a partial response, and those were stratification factors. The study treatment, the assigned treatment was continued for until the time of disease progression, or if there was no disease progression, it was stopped at 2 years. For patients who entered the study with some evidence of disease, as I discussed with partial responses, and that disease was still stable at the 2-year mark, there was the opportunity for them to stay on their assigned treatment beyond 2 years with conversation with the medical team. The primary endpoint for SOLO1 is investigator-assessed progression-free survival, and that is defined as the time interval from randomization until such time as that patient progresses by virtue of measurable disease on their CT scan. Key secondary endpoints are progression-free survival as measured by the Blinded Independent Central Radiographic Review, or BICR, progression-free survival 2, which is measured from the time of randomization to SOLO1 until such time as of the patients who've recurred and get another therapy, they progress again. That's PFS 2, time to first subsequent therapy, time to second subsequent therapy, and then our key quality of life endpoint was health-related quality of life as measured by the TOI. So the results of primary endpoint of SOLO1, just to comment that between the two randomization groups, baseline characteristics were very well balanced as controlled by randomization, and our median duration of follow-up is 41 months in both groups. Here are the survival curves. For the placebo group, we have a median progression-free survival of 13.6 months, which is actually exactly what we predicted it would be back in 2011 when this was designed. Among the women who were randomized to the olaparib arm, their median progression-free survival has not even been reached yet. But the differences between the curve give us a hazard ratio of 0.3 with a highly statistically significant confidence interval, and which tells us, based on sensitivity analyses that the improvement in progression-free survival for women who were randomized to olaparib is about 3 years beyond that of women who were randomized to the placebo arm. Key secondary endpoints will be shown in detail tomorrow, but they include progression-free survival 2, which remained superior for patients who were randomized to olaparib with a hazard ratio of 0.5. Both time to first and time to second subsequent therapies remain statistically significantly superior for patients randomized to olaparib, and our health-related quality of life as measured by the FACTO TOI showed no clinically relevant decrease in baseline quality of life among patients who were randomized to olaparib. The safety profile for SOLO1 was very much in line with every other study evaluating olaparib in every other line of therapy. We saw very manageable, low-grade adverse events, and is demonstrated by the fact that only 11.5% of patients discontinued olaparib therapy due to adverse events, and over 70% of patients who started olaparib on SOLO1 maintained at their starting dose throughout their participation in the trial. Gives us a lot of reassurance that this is a highly tolerable and safe regimen. So in conclusion, we feel that the SOLO1 trial has demonstrated really an unprecedented improvement in the progression-free survival in patients with a BRCA mutation who have advanced ovarian cancer when olaparib is incorporated following platinum-based chemotherapy. A key point here is that there was no change in the Kaplan-Meier curve at that 2-year mark when we stopped the olaparib or placebo therapy. And so it appears that the benefit of olaparib maintenance is extended beyond even the 2-year time point during which patients were receiving treatment. We do find a statistically significant improvement in progression-free survival 2, which indicates to us that there's no detriment to using olaparib following frontline chemotherapy for patients who do recur and need a subsequent therapy. And there were no new safety signals raised that bring use of frontline olaparib any level of concern. And so in summary statement, we believe that the SOLO1 data really prompts a change in the standard of care for women with advanced ovarian cancer who harbor a BRCA mutation. And we hope that this will be available to patients relatively soon. And that's the data.
Thank you.
As you heard earlier from Dr. Banerjee, I mean, PARP inhibitors have made a big impression in the management of recurrent ovarian cancer. But you also heard that when patients have a recurrence, eventually that becomes a fatal disease. And although we can extend survival or extend the time the disease is controlled, they will die of their disease. So the real aim of our treatment now needs to be very much focused on preventing that first recurrence, which occurs in 70% of patients. And actually, if you look back at all the trials that have been done, the drugs that have been developed over the last few years, we've actually made very little impression on the first-line treatment of women with ovarian cancer. There's still 70% of these women will have a recurrence. So the opportunity to bring a PARP inhibitor into the first-line setting was a very interesting opportunity, particularly in women with a BRCA mutation. And we know that the PARP inhibitors are more effective in patients who carry a BRCA mutation. Although they will work in many other groups of patients, they are most effective in those with a BRCA mutation. So this was the best group to select, the testing of a PARP inhibitor in that first-line setting. And the data that you saw showed actually very robust progression-free survival data, because the analysis was done when all patients had been followed for a minimum of 3 years, having stopped the PARP inhibitor at 24 months, which was the planned time to stop. And if you looked at those curves, and as Dr. Moore pointed out, actually the shape of the curves did not change beyond 2 years. So it does not seem as though the curves are coming together after the treatment has been stopped. Now that's a very, very interesting result. Of course, we're going to have to wait until the overall survival data mature. That I think will be a long time, because these patients with a BRCA mutation often survive for long periods of time. But we haven't even seen the median progression-free survival being reached yet, which again is very encouraging. And comparing that with all the trials that we've done with other cytotoxic chemotherapy and drugs like bevacizumab, we've just not seen median progression-free survivals that good at that period of time, out to 3 years. So I think there's a real hope that this treatment will perhaps lead to an increase in the cure rate, which will be reflected by a reduction in the first relapse rate. We'll need to wait longer for that, but there's no doubt that this is a big step forward for the patients with BRCA-mutated ovarian cancer. There are many challenges, not least the access to the drug and the cost of the drug, but also the testing of patients for a BRCA mutation. That has improved over the last few years as PARP inhibitors have become more widely available, but we will need to get that testing done earlier in patients at diagnosis to know whether they will be able to qualify for olaparib maintenance after the end of their first chemotherapy. And that produces some logistical challenges in many countries and many regions. But overall, it's, I think, a very big step forward and very much a landmark trial for the treatment of patients with ovarian cancer.
Thank you very much.
And we are a network of 135 patient advocacy organizations from around the world, so I think 44 countries as it currently stands. We've just completed what we believe to be the world's, the largest study of its kind in relation to a global survey of ovarian cancer patient experience. So we have responses from over 1,500 women from 44 countries to our survey. And it's there are a wealth of findings, but right from kind of awareness of ovarian cancer pre-diagnosis through to delays in access to treatment. But I think today, in terms of these amazing and exciting results, the key things that strike me from thinking about the patient perspective is the absolute urgency and need to ensure that people who were women who were diagnosed with ovarian cancer have access to genetic testing, that they are aware of the significance of family history, the importance of pre-diagnosis testing where there is a strong family history, and the urgency for access to genetic testing where it is when they are diagnosed and it is known. Our study found huge variations. For example, in Japan, the average of pre and post-testing was under 10%. In the US, I believe it's above 80% and everything in between. So I think that's a real takeaway message. And then secondly, access to specialists and specialist treatment and drugs that are available and are coming onto the scene. Again, the study found wide variation globally, but the one common result from all of the work that we did from all of the women that responded was really the need to do better for ovarian cancer patients, to ensure that these important breakthroughs are moved through quickly and that they have access quickly, and that the infrastructures and healthcare systems are really there to ensure that these women are able to access these important developments.
Thank you.
Thank you.
Now, before